Thank you, Professor Magdi. That was very tender talk about me. I'm really honored that Professor Magdi was my mentor since 2012. And he introduced me to anesthesia as an art and as a science. And I'm also thankful to Dr. Walid Al-Habashi for allowing me to this opportunity to give this lecture, and I wish he will he get well very soon. My name is Yusuf Aoud. I'm an anesthetic registrar in Our Lady of Lourdes in a hospital in Drogheda in Ireland. I'm a previous ALS instructor, and I'm currently an instructor in ACLS, American Heart Association, and I'm a member of the Irish Heart Foundation for 2 years now. From the name Saving Lives Academy, I think there is nothing can save lives more than masterized the resuscitation skills. And I believe many of the attendees today are either ALS or ACLS instructors, or maybe some is even course directors. Today's lecture is about ACLS 2020 updates, and there are many actually, and it was a very good idea to have a look and know about the new updates as per the American Heart Association. No, it's okay. So by the end of this lecture, we will know the role of CPR in saving lives, identify the 2020 ACLS science updates, describe the rationale for these updates, apply updates to our training, and how to maintain and retain adequate resuscitation skills. So CPR, by definition, is an emergency life-saving procedure performed when the heart stops beating. CPR, especially if administered immediately after cardiac arrest, studies have shown that it can double or even triple a person's chance of life. The majority of out-of-hospital cardiac arrest occurs at public settings, about 18.8%, homes, residences, 69.5%, and nursing homes, 11.7%. And according to the 2014 data, nearly 45% of out-of-hospital cardiac arrest victims survived when a bystander CPR was administered, and myself have witnessed two victims who suffered cardiac arrest has been saved by a family member or by a neighbor. And I remember the last case, the neighbor of the victim had a recent BLS course, and he managed to do an effective CPR and brought an AED machine and give a shock to the patient. And actually, the patient had a ROSC, return of spontaneous circulation, before the ambulance come, and that was really amazing. And I told this man, you really saved this man's life. Interesting to know the history of CPR. We'll go through very quickly on between the 1530 and the 18th, the bellows method first used by the Swiss physician Paracelsus, and the same basics have been applied to the early ventilator we are using these days. On the 1856, Marshall Hall, which is a scientist in London, introduces alternately repositioning the patient face up to side, and he updated the approach by adding pressure on the thorax. And actually moving the patient from supine to Browning. Again, in 1858, Henry Sylvester, also a scientist in London, creates the chest pressure arm lifting method. All these, and also there was a few trials putting the victim, hanging the victim on a tree upside down, trying to move him up and down, and other to put the victim on the back of a horse, of a running horse. All these have the same idea of applying pressure, external pressure on the chest, allowing the air to move in and out. On 1903, in Cleveland, Ohio, Dr. George Criles's research confirms that external chest compressions did restore circulation in dogs. In 1924, the first American Heart Association meeting in Chicago, done by 6 cardiologists, and nearly a century later, the American Heart Association has become the world leader in CPR and emergency cardiovascular care, training, and education. In 1956, Dr. Elam and Dr. Peter Safar proved that mouth-to-mouth resuscitation is an effective life-saving method, and for the first time, an external defibrillator successfully restores a steady rhythm to a quivering heart. Harvard cardiologist Dr. Paul Dole leads the study with funding from the American Heart Association. And after his name, defibrillators have been manufactured after his name. On 1957, John Hopkins' team unveiled the first portable external defibrillator. On 1960, Resusci-An is born. This is the simply the Manucan we're using today for our resuscitation and CPR training. On 1990s, public access defibrillation program provide training and resources, including AEDs to the public. In 2010, the American Heart Association published the 2010 American Heart Association guidelines for CPR. Now, we'll just go for a refreshing questions. I believe it's, I chose a very, very simple question, and we'll go through very quickly. Each question I will allow only 15 to 20 seconds to answer each question, just for the sake of the time. So we'll start the first question, and I hope everybody will participate. So first question is, what is the correct dosing regimen for epinephrine to treat pulseless electrical activity or asystole? A, 300 milligram bolus. B, 1 milligram intravenous or intraosseous, repeated every 8 to 10 minutes. C, 1 milligram, repeated every 3 to 5 minutes. D, 0.5 milligram, repeated every 8 to 10 minutes. So I'll give 10 more seconds for the people to answer, as it's the first question. Okay, now we'll see the correct answer is C. So 92% give the correct answer. That's brilliant. Question number 2, synchronized cardioversion is recommended for A, monomorphic ventricular tachycardia in a stable patient, B, pulseless rhythm, C, unstable supraventricular tachycardia, D, polymorphic ventricular tachycardia. Again, 20 seconds. Okay. So the correct answer is C, 61%. All right, okay, so we always make it simple during our teaching. So if the patient had a life-threatening arrhythmias and the patient is stable, we always go for the pharmacological or the medical treatment. If the patient is unstable, we tend to go for a cardioversion. So for monomorphic ventricular tachycardia in a stable patient, we tend to, as per guidelines, we tend to go for pharmacological, like amiodarone infusion. For a pulseless rhythm, this is a non-shockable rhythm that needs immediate CPR and adrenaline. For a polymorphic VT, there is no R waves, so cardioversion will not be effective in such situation, and defibrillation will be the treatment. Question number 3, interruptions in chest compressions should be limited to A, less than 10 seconds, B, 2 seconds, C, 5 seconds, D, there should never be interruptions in chest compressions. Again, we'll give 20 seconds. So the correct answer is A, less than 10 seconds, 66%. I'm wondering, like, there should be never, yes, there should be never a interruption to chest compression, but the question says limited. We have to focus on the words, should be limited to, that interruption must happen anyway. Question number 4, single rescuers should use a compression to ventilation ratio of A, 15 compression to 2 breaths, B, 90 compressions to 2 breaths, C, 15 compressions to 1 breath, D, 30 compressions to 2 breaths. Again, 20 seconds. That's an easy one. Well, the 75%, that's good. That's the correct answer. D, 30 compression to 2 breaths. The last question. When communicating with the team members, the team leader communicates by taking these steps. The team leader gives a message, order, or assignment to a team member. By receiving a clear response and eye contact, the team leader confirms that the team member heard and understood the message. The team leader listens for confirmation of a task performance from the team member before assigning another task. I'll give an example. So the team leader asks whoever takes the medication, give 1 milligram of adrenaline. The member replies 1 milligram of epinephrine. The team leader should reply to him, say yes, 1 milligram of epinephrine. After giving the epinephrine or the adrenaline, the member says 1 milligram of epinephrine given. What do we call this? A, closed loop communication, B, collaboration communicating, C, dictatorial communication, D, emergency response communication. Okay, so the correct answer is closed loop communication. That's correct, 73%. That's good. Okay, now we are going to move along with the ACLS 2020 science updates, and hope you enjoy the lecture. So we'll go straight away. The adult chains of survival. There is a 6-link recovery has been added, and the rule of the recovery is to optimize physical, cognitive, and emotional status of the rescued person, and to rehabilitate the patient for social and rule functioning. We'll go through the algorithms now. The first algorithm is the adult cardiac arrest algorithm. Few changes. First change, there is the American Heart Association emphasized early administration of epinephrine once the patient is diagnosed with a non-shockable rhythm. The second change is adding lidocaine or reintroducing lidocaine again for the shockable rhythm. In the previous 2015, amiodarone was a drug of choice to be given with a shockable rhythm after the third shock. But now lidocaine is now equipotent to amiodarone, so either amiodarone or lidocaine can be given in a shockable rhythm scenario. And another line has been added, and it's very realistic to consider appropriateness of continued risk resuscitation. How many times we are resuscitation? We are resuscitating a patient, and we don't know when to stop the CPR or is it right to stop the CPR? For many patients who have a poor outcome, multi-morbidities, CPR cessation should be discussed. Should be a multidisciplinary decision to stop the CPR, and it's very realistic to add this line to the algorithm to consider stop the CPR in some scenarios. We'll go to the second algorithm, which is the adult tachycardia algorithms. No major changes also. The IV axis and the 12-lead ECG is put earlier on the first box of the algorithm instead of putting it later. Very reasonable to put an IV axis for a patient who is suffering a life-threatening tachycardia, and also to do a 12-lead ECG if possible. A new box has been added, which is also very realistic, because what happens usually with after recovery from life-threatening tachycardia, this patient comes back again to tachycardia, and it's very important to know the steps that should be taken if a refractory tachycardia happens, which is looking for the underlying cause, need to increase the energy level for the next cardioversion, or addition of antiarrhythmic drug, and of course always seek expert help. The third algorithm here, the bradycardia algorithm, no major changes. It's mostly numbers. Surprisingly, the atropine dose has been doubled from 0.5 milligram to 1 milligram bolus, but the maximum dose is still 3 milligram. I'm not here today to explain the ACLS algorithm. I'm just emphasizing the updates. I presume that we all have an idea about the algorithms. The other change is the dopamine IV infusion changed from 2 to 20 microgram per kg per minute to 5 to 20 microgram per kg per minute. And the last thing added is the considered possible hypoxic and toxicological causes, which has been explained later on a separate box on the right. Now, what you're watching here is the old version of the post-cardiac arrest care algorithm, 2015. And as instructors, we suffered a lot to explain this algorithm to our candidates, because this algorithm lacks the sequel of A, B, C that we all know of, and lacks lots of vital information. Another defect in this algorithm is the neurological status of the patient fate. How are we going to manage the neurological deficit that happened to the patient during the CPR? So I'm really happy that we are not using this algorithm anymore, and we have another more realistic and more pronounced one here. If I did zooming here, we will find more clearly. This is a more explaining and covering most of the items that should be ticked after the patient's cardiac arrest, as we can see here, and major changes has been happened to it. We'll start first. An initial stabilization phase has been explained clearly, the same way that we usually teach our candidates, which is A, manage the airway, B, manage the respiratory parameters to reach the specific targets shown here, and manage the hemodynamic parameters. Another change here, the target of oxygen saturation is set between 92 to 98%, instead of more than or equal 94, give you a bigger range of oxygen target. And a new box has been added here, consider for emergent cardiac intervention if the patient has STEMI, or unstable cardiogenic shock, or a mechanical circulatory support required. And here, if the patient follows, after following the question of if the patient follows commands, the previous version of post cardiac arrest care algorithm only focused on one thing, which is TTM, which is a targeted temperature management. But what about the neurological status of the patient that is affected by the oxygen debridement during the cardiac arrest, and what are the management of the neural status of the patient? So 3 elements has been added, which is obtain brain CT, EEG monitoring, and other critical care management. 2 boxes added to H's and T's on the right, explaining the initial stabilization phase and continued management and additional emergent activities, which is really great. Now, cardiac arrest in special situations. Just for those who don't know, in the ACLS provider book, there is no special situations, which limited our choices to give scenarios. Like previously, I can't really give a scenario to a candidate about a pregnant woman who had a cardiac arrest, which is not uncommon actually. A pregnant woman has multiple risk factors. Like I can't give a scenario of a pregnant woman who had pulmonary embolism or amniotic fluid embolism or major post-obstetric hemorrhage. What happened here, for those who don't know, the special scenarios are present in ACLS, but not on the ACLS provider book. It's present in ACLS EP. There is another course called ACLS EP for ACLS for expert practitioners, which has many special situations. So what the American Heart Association did, they brought 2 special situations, which is a cardiac arrest in pregnant woman and cardiac arrest in opioid overdose, and not only brought these 2 situations from this book, but also had put some modification to it, as we will see here. So this is a new cardiac arrest in pregnancy in hospital ACLS algorithm. There is a few changes. They removed the step to assess the hypovolemia and treatment. And there is a line added, which is administrate 100% oxygen, avoid excess ventilation, emphasizing the importance not to hyperventilate the pregnant woman, because this will not only reduce the cerebral blood flow, but also will reduce the placental blood flow and will cause a more fetal bad outcome. Changing here in the timing of performing the perimortem cesarean delivery, and instead of 4 minutes changed to 5 minutes, giving 1 whole minute to the obstetrician. I'm sure they are happy about this. And a new a separate box about the maternal cardiac arrest management, including team planning, priorities for pregnant women, the goal of perimortem cesarean delivery, and as we mentioned, the timing for perimortem cesarean delivery. Another separate recommendation for cardiac arrest in pregnancy. First is airway management should be prioritized, because as we all know, pregnant woman has higher oxygen requirement, has a lower functional residual capacity, and because hypoxemia will be reflected on the fetal outcome. So airway management should be quick, should be done by the most experienced person, which is usually the anesthetist. Another thing, evaluation of fetal heart during CPR is not helpful. because simply it will interrupt the CPR, and there is no, it will not affect the way we deal with the CPR in such scenarios. We go quickly through the other. We go through the other algorithm, the opioid associated emergency for healthcare providers, and a few changes also. There is a clear step now to prevent deterioration with an initial assessment. And there is a clear question in the middle. Is the patient breathe normally? Yes or no? And naloxone should be considered if the patient had cardiac arrest. I mean, like he had a respiratory and cardiovascular arrest. And if the patient has a respiratory arrest but with pulse, we may give naloxone. We'll move again to the next algorithm, acute coronary syndrome. A few changes as well. Change the transfer to not only to the ED, but we actually can transfer to the cath lab. In my hospital, the nearest cath lab in Mater Hospital, it's about 20 to 30 minutes. And what we usually do in a critically patients that needs an urgent PCI, we liaise with the cath lab in Mater Hospital, and we go with the ambulance direct to the cath lab instead of wasting time to the ED. Again, time equals life. So making it loud and clear to save life in the algorithms was a brilliant idea. So this is a vocabulary. I think that the previous algorithm had a vocabulary defect that was targeting the first medical contact to balloon inflation is 90 minutes. It will be understood that you have to wait for 90 minutes to deliver the patient to the cath lab, but it's just a vocabulary defect. Instead of a target of 90 minutes, it's 90 minutes or less. Again, after ECG interpretation, there is two big boxes, one for ST elevation and one for the non-ST elevation. And under the non-ST elevation, two big boxes, one for the normal ECG and one for the abnormal ECG, but without ST elevation. And the last algorithm, the adult suspected stroke algorithm. The first change is that there were two, usually in the old one, there are two boxes. It's a critical EMS or emergency medical service assessment and action are separate. And now they are just merged these two boxes into one box and added two lines, which is initiate a stroke protocol and stroke severity tool. The stroke severity tool is a bit long questionnaire, but if it did happen before reaching the hospital, it will help in the management of such patients. Also, again, likewise, the acute coronary algorithm, the ED or the brain imaging suite. So the ambulance can actually go direct from the patient can go direct from the ambulance to the imaging suite to do an urgent CT. As we mentioned before, time equals life. It will save lots of time and improves the outcome of the patients. And also, the stroke team is better to meet the EMS on arrival and describes transferring the patient direct from the ambulance to the brain imaging suite is a best practice. There is a huge change on the lower part of this algorithm. So usually at this part here in the atiplase candidate, there was atiplase were not mentioning. They were actually mentioning antifibrinolytics, but now they are specifically mentioning atiplase as a drug of a choice. when usually in the previous algorithm, when the patient is not is a candidate for Atiplase, they added 2 boxes mentioning that review the risks with the family and ensure that the patient is not on any anticoagulants or antiplatelets, which should be ruled out once the patient is already a candidate for it. So it doesn't make any sense to add again the precautions to give the Atiplase because the patient is already a candidate. Another thing is if the patient is not a candidate, they just mentioned give the patient aspirin and admit to stroke pathway, which is not realistic at all. This patient still have an option, which is the endovascular therapy. So if the patient is not a candidate, that's the new thing between the 2 white curves here. As you can see, consider endovascular therapy, perform CTA and perform CTB as indicated, and continued if the patient is a candidate for endovascular therapy. Yes, transport to the cath lab very quickly to do an endovascular thromboembectomy and then admit to the neurosurgical ICU. If not, admit to stroke unit or neurological ICU. And also they declare that endovascular therapy could be done up to 24 hours. Now, what you see, that's an amazing illustration for a neuroprognostication. It's very important to know when to examine the patient and how to examine the patient and what we are looking for about in terms of neurological condition. It's a timely framed neuroclinical assessment, perfectly done, mentioning the clinical management, imaging, electrophysiology, clinical examination, and serum biomarkers, neuron-specific enolase as a prognostic factors with a timely manner. Now, talking about the real-time audio-visual feedback, I'm not sure that we have, all of us have been seen, have seen this kind of tool, but very simply, this tool is to monitor your quality of chest compression, how deep you are, how good you are in doing the chest compressions, and give you an audio and visual feedback of what you're doing. In the next slide, I'm going to show you a video of the defibrillator we are using in our hospital, and I'm going to show you the real-time audio-visual feedback that we are using and how good they are to maintain a reasonable cerebral perfusion by doing an effective CPR. So we're going to see the video together. First, I need to adjust the setting again. Sorry, Dr. Walid.
It should be fine.
Okay, done.
Real CPR help. For adult patients, the one-step complete and CPR electrodes include a CPR sensor. The CPR sensor monitors the rate and depth of chest compressions and sends this information to the R-Series. You should always use a backboard or CPR mattress when administering CPR. For adult patients, real-time feedback displayed on the CPR dashboard includes compression depth indicator, compression rate indicator, release bar, perfusion performance indicator, PPI, audio and messaging prompts, and idle timer. The CPR dashboard on the R-Series defibrillator provides you with a digital reading of each and every chest compression. If your compression depth or rate falls outside of guidelines, the numerical value of rate and/or depth will turn red on the CPR dashboard. The R-Series defibrillator will also provide an audible message, "Push harder," and a metronome will beep to help you reach 100 compressions per minute. This real-time feedback can help ensure you are doing high-quality chest compressions. The release bar measures release velocity to determine that rescuers are allowing sufficient time for cardiac filling. The bar should be completely full of color. If the color begins to decrease, make certain the rescuer is coming completely off the chest for full recoil. The perfusion performance indicator integrates compression depth, rate, and interruption times into one visual indicator. Maintaining maximum value, full indicator, provides visual indication of performance to the current guidelines. When compressions have been interrupted for an extended period of time, idle time is displayed in minutes and seconds. This is a visual reminder to help minimize pause time.
I'll go back here. Just give me 1 second. Allow me 1 second. Okay, so as we can see here, we have three things. The release bar, sorry. Again, this is the depth that should be between 3 and 5 to 6 centimeters, but here it's in inches. Rate between 100 and 120. If your depth or rate fall below or over this, it will give you an alarm. This release should be full. If it's not full, means that you don't give sufficient recoil of the chest. And PPI is the general information about how good the CPR is going in general, which indicates a good perfusion. Now, I believe that most of us doesn't have this machine in their hospital. So we have an alternative. Yes, we have an alternative. We can use, now everyone has a smartphone in his pocket, and there are some good applications that we could use to give a useful visual and audio feedback. As we can see on the picture on the right, that there is also not only a smartphone can be used, but you can also use a watch, which is better. But either can do the job to give you a real-time feedback about chest compression. Using mobile phone has been recommended by the American Heart Association. According to the International Liaison Resuscitation, Committee of Resuscitation, ELCOR, a systemic review has revealed that using of smartphone applications and text messages has improved the rate of CPR, reduced the time to defibrillation, and increased rate of survival to hospital discharge. Physiological monitoring of CPR is recommended now by the American Heart Association, like arterial blood pressure if we have an arterial line, end-tidal carbon dioxide, and the concept that end-tidal carbon dioxide during CPR is only attached to the endotracheal tube or the supraglottic airway is not anymore. You can actually now attach the end-tidal carbon dioxide if you are using a bag mask device to monitor the quality of chest compression. In respiratory arrests, we usually, in the past, we say give one breath every 5 to 6 seconds. Now it's only one breath every 6 seconds, means 10 breaths per minute, just to eliminate the confusion. Should I give one breath every 5 or every 6 seconds? The other thing, and it's really interesting, that as we all know, we give 2 chest compression after, we give 2 breaths after 30 compression if the patient is not intubated or doesn't have a supraglottic airway. And if the patient has is intubated or have a supraglottic airway, you give 1 breath every 6 seconds. Interestingly, if you are about to put an endotracheal tube or supraglottic airway, you can actually give 1 breath every 6 seconds during compression. But that's mentioned only if you are about to intubate the patient. The rationale behind this is not explained yet, because we don't have the ACLS provider book. It will be published in a couple of months. But the rationale, from my point of view, is that we are trying to pre-oxygenate the patient and trying to minimize the chest compression interruption as much as possible. That's why we are continuing chest compression and we are continuing ventilation, not waiting for 30 compression to get oxygenation, for better oxygenation just before, just the moments before putting the tube. Epinephrine infusion used to, during cardiac arrest, used to be between 3 and 5, and now it's recommended to be every 4 minutes to match every other rhythm check. Another way to eliminate any confusion, is it after 3 minutes or 5 minutes? So it's now every 4 minutes or every other cycle. And oxygen targets has been clearly illustrated here. That should be greater than 94% for stroke and general care, 92 to 98% for post-cardiac arrest care, and less than 90% for acute coronary syndrome. Double sequential defibrillation not supported anymore. So for those who don't know, the double sequential defibrillation is simply given a shock by 2 defibrillators at the same time. Some studies in the past mentioned that it's better to do the shock with 2 defibrillators rather than 1, especially in refractory or persistent ventricular fibrillation. But the ELCOR, again, one systemic review of ELCOR has revealed that it's not favorable and not recommended to be done anymore. The point of care ultrasound for prognostication during CPR, one systemic review have revealed that it did not change the outcome of the patients, and it's better not to be done during CPR unless it will change the way of management and is being done by a very experienced hand. Another thing about the intraosseous axis, in the previous recommendation that intravenous or intraosseous are the same, but 5 retrospective studies has revealed that using the IV axis for resuscitation has a better outcome. So it's better to keep searching for an IV axis to give the resuscitation medication rather than go the easier way and do the intraosseous route. Okay, that's from my point of view, that's the most interesting part, the CPR coach. Simply, the CPR coach is a new rule added to the team members. The whole idea is the CPR coach is monitoring how good you are performing the chest compression and the ventilation. myself, I started to apply this rule in the hospital I work in, and the last case I applied this rule, I was managing the airway, and I asked the team leader, after securing the airway by endotracheal tube, to sign another member to do the bagging, 1 every 6 seconds. And I did the rule of CPR of a patient of about 42-year-old patient who had revealed later on that he had a complete occlusion of the left main coronary artery, and I was monitoring the quality of chest compression using the audio-visual feedback, and this patient took about 1 hour and a half during resuscitation, and surprisingly, after this, the patient had ROSC, and he was able to open his eyes and even move his head while calling his name before sedation. What I'm trying to say is that a CPR coach will ensure the good quality, a good quality chest compression, and this will be reflected in a good cerebral perfusion during CPR and the better neural outcome, rather than have a patient who had survived a cardiac arrest but with neurological deficits. And also allowing the team leader to focus on other areas of critical care instead of focusing on too many things. How good the chest compression is going, when we give the adrenaline, is this shockable or rhythm or not? So I believe in the future the studies will show that the CPR coaching will improve survival rate and outcomes. So what happens after the patient recovers from a cardiac arrest? There should be a multidisciplinary plan for discharge, as we mentioned before, to optimize the physical, cognitive and emotional phase, and rehabilitate the patient for social and rural functioning again. Debriefing and referral for follow-up for emotional support for lay rescuers is actually very important, especially during the stressful time we have now during the pandemic. Many healthcare workers exposed to post-traumatic stress disorders, but they don't talk about it, and this will be reflected on their work. In Ireland, the healthcare workers have the ability to ask for counseling up to 3 sessions free of charge, and can be extended if needed, but we should ask for it if we needed to. So what's the best practice for us? ACLS course participation typically should be done every 2 years. And studies have shown that if at least 1 or 2 of the CPR or the resuscitation team have done their ACLS, the survival rate of the victims increases. And studies also shown that booster training and spaced learning on the 2 years area or period will help in retaining ACLS or resuscitation skills, and it's a good practice. In situ education is well encouraged by the American Heart Association. In situ education means that doing from once in a while training in the department you're working with, like in the emergency department or in the theater or in the ICU, doing quick training at any time to familiarize yourself with with such a situation in your environment. But care should be taken from displacing the actual medication of the patient and causing a drug error. So I don't know if, Dr. Walid, if we have time for another questionnaire or not. Dr. Walid?
You should be fine. We have
Okay,
5-6 minutes more.
Okay, so we'll go quickly for this questionnaire. This is just to ensure that we had a good feedback and we understand today's lecture. So question number 1, changes to the adult cardiac arrest algorithm was modified for patients with non-shockable rhythms include: A, amiodarone is preferred over lidocaine. B, moved epinephrine to as soon as possible for non-shockable rhythm. C, atropine can be used alongside epinephrine. D, chest compression should be more than 6 centimeters. Moment of the truth. So B is the correct answer, 77%. That's very good. I'm really thrilled. Question number 2, the post-cardiac arrest care algorithm is updated to A, oxygen saturation of 88 to 96%, B, separated out initial stabilization phase to include managed hypothermia, C, added a step to consider treatment of seizures, D, added obtained brain CT, EEG monitoring, and other critical care management if the patient is comatose. 59%, that's good. Question number 3, the 2020 guidelines for opioid-associated resuscitation emergency algorithm for healthcare providers include: A, prevention on deterioration is not included. B, cardiac arrest is more prominently addressed in the beginning with is there a pulse as an initial decision. C, although naloxone is still recommended for opioid-associated emergencies, it should be considered for preventing deterioration and cardiac arrest and given during respiratory arrest. D, according to the algorithm, if the patient has a pulse, you do not need to support ventilation. Very good, 71%, great. Question number 4, the adult bradycardia algorithm includes updates changing. The changes include the following except: A, atropine dose changed from 0.5 milligram to 1 milligram, dopamine dose changed from 2 to 20 microgram per kg per minute to 5 to 20 microgram per kg per minute. C, if the patient is asymptomatic, you must initiate external pacing. D, under identify and treat underlying cause, added consider possible hypoxic and toxicological causes. Oh, 41%, quite frustrating. So the correct answer is C. If the patient is asymptomatic, you must initiate the external pacing. Last question, a revised algorithm is provided for cardiac arrest and pregnancy. Changes include the following except: A, team planning. B, prioritize of high quality CPR and relief of aortocaval compressions with lateral uterine displacement. C, goal of perimortem cesarean delivery. D, deliver in 6 minutes depending on provider resources and skill sets. Oh, that's quite frustrating. So the question is, changes include the following except. So we have to read the question very carefully. So deliver in 6 minutes is the answer. So the A, B, C are right, and D is wrong. The delivery should be in 5 minutes. So the summary of ACL provider manual updates first highlights the 2 main themes: preventing arrest and high performance team. Second, new information under cardiac arrest, selected special situations, which we discussed: maternal cardiac arrest and opioid overdose related cardiac arrest. Revised illustrations, CPR coach rule, and expanded information on high performance team. Thank you. And I don't know if we have time for questions, Dr. Walid.
Thank you, my dear Sanju. And now I can't find any question. If yes, the first question came from Ryan. Thanks. Please, this is running chats. Any question from the audience? Yeah. What about epinephrine and shockable rhythm? What about epinephrine and shockable rhythm? You hear me, Yusuf?
Okay, so I'm not totally understand the question. What about epinephrine shockable rhythm? We should give epinephrine. We should give epinephrine in shockable rhythm after the second shock as per ACLS. There is a difference between ACLS and ALS. In ALS, you give it after the third shock, but epinephrine in shockable rhythm still can be given after the second shock. There is no mentioning about changing this, and with the same dose, 1 milligram. The second question.
Wait, Yusuf. Just to clarify this point, whether second shock or third shock, I think the message is clear that we shouldn't start by epinephrine shockable rhythm.
So
I know the way of treating is not hurry to give epinephrine. So you should clarify that.
So the question is about shockable rhythm, so the shockable rhythm means that the patient will have first shock, second shock, and after the second shock, we give epinephrine, and then the third shock, after the third shock, if there is no ROSC, we give amiodarone as before. If the patient is in non-shockable rhythm, at this point, we will give the epinephrine as soon as possible.
No, I'm just debating with you about that. It should be clear that we shouldn't start in shockable rhythm by epinephrine at 0 time.
Well, they did not clarify because it's already, because there is no change. This is what was we are practicing on the previous guidelines on algorithm. So that's maybe the reason they did not mention anything about giving epinephrine in shockable rhythm, because there is no change.
Second question: do you do full resuscitation for a COVID-19 and multi-organ failure terminal?
Okay, so there is another algorithms for ACLS and COVID patient, and that's not in our scope today. But very briefly, for a patient, for resuscitation of a COVID patient, you should always protect yourself. No matter how bad is the patient, if the patient is a COVID-19 or a suspected COVID-19, you should wear your full PPE. The second thing is that there is a priority to put the tube in and actually interrupt the chest compression. So you can ask the team leader. I will gently kindly ask you to stop the CPR, to put the tube if you are experienced enough, and immediately attach the tube to the HME filter to prevent the spread. The rationale behind this is that the bag mask will increase the chances of aerosolized infection. And the other thing is actually you can use the ventilator during the chest compression instead of bag mask for the same reason. About the multi-organ failure, again, there will be no difference between a patient with a COVID with a multi-organ failure or none, depending on the policy in your hospital or the capacity in your hospital. And always discuss this with the consultant or whatever, the ICU. It depends. It is different between hospital and another. If this patient is a COVID with multi-organ failure, should we resuscitate or not? I cannot actually answer this question for you. It depends on where you're working and how bad the condition of the patient is. And did you actually able to discuss this with the family or not? Is there any other?
A nice debatable question: when to stop CPR if no return of spontaneous circulation?
Again, there is no mentioning in the updates about this. Again, this depends on many reasons. It depends on the law of the country. Like I know in Khalij, it's different from Europe. And so again, it depends on the law of the country, it depends on the policy of the hospital. This is the first thing. The second thing, to stop the CPR is a multidisciplinary team, not done by only one. It should be agreed by the team doing the CPR and with a liaison with the consultants. If you have, if you're not a consultant, liaison with the consultant, even by telephone, asking giving the whole information and giving the decision. So again, it depends on where you're working, and also in a discussion with the family is a very good idea before taking this decision.
Last nice question about organizations. Who is the team leader in your institute?
So in my hospital, the team leader can be anyone who is qualified in terms of he had an ACLS course. But in my hospital, the team leader usually either the ED registrar or the medical registrar. Usually, the anesthetist is taking over the airway and helping in other things like giving hints to the team leader kindly, like have we had any gas yet, or sorry, any VBG yet, or have we had electrolytes? That's for example, and also can put lines in after ROSC. So the team leader is usually the medical, one of the medical doctors or the emergency doctors.
Thank you, Joe. Thank you, Dr. Suhair, for this nice night. And now I think Dr. Walid has a surprise for all of us, for the audience. Please, Walid.
Okay, thanks so much for your attendance here. We still have 159 attendees. It's not a bad time to launch the new membership protocols or membership classes on Saving Lives Academy. We have silver membership, golden membership, and diamond membership. 3 classes of membership. I think a lot of people had taken courses with Saving Lives Academy. You know the quality of the courses and conferences presented with the Academy. So we're still presenting free days and free membership, and all the free stuff that presented over the last year is definitely untouched. So these extra membership classes is for definitely the precious courses that was presented previously on small amount of attendees, like 8 to 10 attendees per the course. Like the critical care echocardiography course that is inclusive of the book price, and there is a transesophageal echo course by Cairo University team, plus the medical statistics course that was presented before. So we are launching booking as well for live course by Dr. Walid Shibl, which is brain ultrasound. You can find the link now available on the website Saving Lives Academy under brain ultrasound section. Dr. Walid Shibl is one of the pioneers and most expertise in doing brain ultrasound and transcranial Doppler. So please feel free to ask any questions about the details on contact at Saving Lives Academy if there is any details required. CME Hours Certificate, a question by Muhammad Ali Yusuf. After the last session of the course, after the last week, which is 3 weeks ahead of now, you will get a certificate from Alexandria University as promised from the first day, 45 hours of CPD points or 45 CME hours from Alexandria University. And you still can claim, if you're working in Ireland, 1 hour or 1 point per lecture in the Irish College of Anesthesia. and that will be included in the certificate as well. Hope you have a good rest of the night, and see you next Saturday with another night of Saving Lives Academy Anesthesia and Critical Care Refresher course. My sincere thanks for Professor Magdi Khalil, Professor Dr. Suhair Sulaiman, and my colleague Dr. Yusuf Awad for the marvelous efforts done tonight. Thanks a million. And I'm really delighted to be back between you here after 2 weeks of sick leave. Thanks a million, and have a good night. Thank you, everybody.
Thank you for all of you, and good night.
Thank you.